All right, so far we've talked about the prevalence of comorbidity and the types of syndrome that are most prevalent in people with substance use disorders: depression, anxiety disorders, personality or externalizing disorders, and in some cases, psychotic disorders. Now we're going to talk about some of the explanations that have been proposed for the co-occurrence of psychiatric conditions and substance use disorders. And these explanations cover three general areas. One is a direct causal relationship, in that mental disorders may be a risk factor for substance dependence and harmful substance use. Mental disorders might also alter the course of a substance use disorder in terms of when it occurs, either early or late, the symptomatology, the treatment response, and long-term outcomes. Thirdly, direct causal relationships might be manifested when psychiatric symptoms are a consequence of substance use disorder. That is, the pharmacological properties of the drug and its effects on mood and thinking and behavior might result from substance use disorders. Indirect causal relationships is when one disorder affects a third variable in a way that increases the likelihood of a substance use disorder. So schizophrenia may cause homelessness, and that in turn may lead to greater exposure to alcohol and drugs. Finally, there may be common factors which increase the risk of both disorders. So let's start with primary mental disorders as risk factors for alcohol dependence. One study examined primary mental disorders. Remember, primary means that the psychiatric disorder came first and the substance use disorder came second. One study examined this relationship in terms of the onset of alcohol abuse and dependence. And a 10-year follow-up was conducted with a representative U.S. sample identified in the National Comorbidity Survey. And 87% of the people who were interviewed earlier were followed up. What was found is that few psychiatric disorders were associated with the onset or the subsequent onset of regular alcohol use over a 10-year follow-up period. The one exception that was correlated with the transition from regular alcohol use to abuse was disruptive behavior or externalizing disorders. And as we've mentioned, externalizing disorders is a cluster of psychiatric, mainly personality disorders, connected with antisocial behaviors, conduct disturbances. It also includes addictions and impulse control disorders. And these disorders often have an early onset and typically precede and predict subsequent substance use disorders. Another theory of the relationship between psychiatric disorders and substance abuse is the self-medication hypothesis. This explains the use of substances by postulating that people select substances that help to medicate or reduce their psychiatric symptoms. So, for example, people who begin to use heroin find that it reduces the aggression and rage that they feel. Or people who use cocaine find that it alleviates the symptoms of depression. So the self-medication hypothesis postulates that people select drugs to medicate other psychiatric disorders, and therefore the psychiatric disorders are responsible for the substance use disorders. A related theory is the tension reduction hypothesis. People, for example, with anxiety disorders use alcohol to relieve anxiety and distress. This is well known. And it could be, though, that this is a reciprocal circular type of phenomenon where heavy drinking precipitates anxiety and distress, which is then reduced by further drinking. But it's certainly consistent with what is known about the anxiolytic effects of alcohol. When alcohol is given in a laboratory situation, people, at least when their blood alcohol levels are increasing, report reduced anxiety, reduced fatigue, reduced depression. And so initially, the short-term effects of alcohol are to relieve anxiety. There are other explanations of comorbidity. For example, that psychiatric symptoms are not a cause of substance use behavior, but a consequence. And here we have a good deal of evidence from different types of epidemiological studies. For example, laboratory studies show that repeated alcohol administration affects mood. If you bring people into a hospital ward and give them access to marijuana or alcohol or even to opioids and observe the changes in their behavior, you can find that over the course of an addiction cycle, as the dose increases, their mood and their anxiety levels become much more volatile, and it seems to be related to the frequency and dosage of their substance use. Another type of research is that the prevalence rates of major depression, for example, are very high in alcoholics. And almost 70% of them seem to have what is called a substance-induced depression. That is, that the chronic use of alcohol seems to precipitate depressive symptoms, and follow-up studies indicate that these depressive symptoms remit with the cessation of alcohol use. In one study, the proportion of alcoholics with a major depressive disorder decreased from 67% to 13% over a month without antidepressant treatment. So it suggests that many people who have depressive symptoms, just like many people who have high blood pressure, could reduce those symptoms merely by cessation or reduction in their drinking. Cannabis use disorders, as we have mentioned, in some cases are correlated with psychotic disorders and can precipitate anxiety reactions as well as psychotic reactions, particularly under high doses of THC. More explanations of comorbidity include indirect causal relationships, with one disorder affecting a third variable in a way that increases the likelihood of the second one. For example, one study showed that the presence of early onset substance use disorder reduces the likelihood of completing high school and entering higher education, which then can cascade into feelings of anxiety or depression, and poor educational achievement might subsequently increase the likelihood of other psychiatric problems. Finally, we have other explanations of substance use disorders co-occurring with psychiatric disorders, common genetic factors, common social and environmental factors. So what we're left with is a complex model that suggests that there are many different paths into the comorbidity or co-occurrence of psychiatric conditions and substance use disorders, both in terms of direct causal relationships where one causes the other and vice versa, indirect causal relationships, and common third factors. In conclusion, psychiatric comorbidity is prevalent in people with substance use disorders. Psychiatric epidemiology, as we've seen, as well as clinical and experimental research, has begun to tease out the possible causal mechanisms. And then what we've also observed, which is quite compelling, is that externalizing disorders are a major risk factor for both substance use disorders as well as psychiatric disorders. Most depression and anxiety in people with substance use disorders, as well as psychotic symptoms, remit with abstinence. And finally, excessive drinking can be both a cause and a consequence of psychiatric disorders.